Good afternoon, everyone, and welcome to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speakers for today, I wanted to do some housekeeping. This CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You will find the evaluation by following the link that will be put in the chat at the end of today's talks or at any time on our website and our email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Speakers are expected to disclose to the audience any real or apparent conflicts of interest. All our presenters for today have disclosed that they have no relationships with commercial supporters that could be perceived as a conflict of interest. It's really a pleasure for me to introduce our speakers today. This is my favorite Grand Rounds of the year. Every year, at the end of the year, our wonderful fellows give their presentations on their research and quality improvement projects for the year. Today, we will be having 4 talks, but really all 6 of our fellows have participated in these projects. I'll start with our first speaker, Dr. Ashok Kannan. He grew up in North Carolina. After completing geriatrics fellowship, he plans to move to Kauai to practice home care geriatrics. He enjoys being outside, especially on the water, and he loves cooking, and he's looking forward to starting a farm on Kauai. So we'll all have to come and visit Ashok if we visit Kauai. Dr. Angela Lowe completed internal medicine residency at Stony Brook University in Long Island. She will be doing a 2nd year of geriatrics fellowship in addition to the JABSOM fellowship in medical education. She hopes to be a clinician educator in geriatrics after graduation. Dr. Shivani Chowdhury is originally from Toronto, Canada. After completing a bachelor's degree in biopharmaceutical sciences, she completed internal medicine residency at MedStar Health in Baltimore, Maryland. After graduation, she's joining Queens as a hospitalist, working at Queens West, and she's looking forward to exploring more of Hawaii. Dr. Susan Christensen is a family physician with over 15 years of primary care experience. She realized the challenges faced by older patients and therefore came back to do a geriatric fellowship. She has an MBA in healthcare administration. She hopes to influence change within the medical business environment so that patients can afford needed services, doctors can earn a living, and the well-being of both remains paramount. She is also staying for 2nd year of fellowship training. Dr. Timothy Chong is originally from Florida. He graduated internal medicine residency at Stony Brook University Hospital in New York, and then came to a fellowship in geriatrics at UH. He will be joining the Queen's University Medical Group post-acute long-term care team next year. But long-term, he plans to use the specialized training to help treat patients in the outpatient clinic setting. We don't have Dr. Elaine Takane here. She's our 6th fellow. She's on vacation today, but she also has participated in 2 of the projects that are being presented today. She's a JABSOM grad, did her family medicine residency in Hilo, came here for geriatric fellowship, and she will be working at Wahiwa in a community health center after graduation. So welcome all the fellows. And I believe Dr. Christensen is going to be doing the first talk. So Susan, please go ahead and share your screen.
Unmute. There we go. Okay. Thank you, everyone. So good afternoon. My name is Susan Christensen, and I am completing my 1st year of fellowship in the University of Hawaii Geriatrics program. I would like to acknowledge my co-authors, in particular, my fellow researcher, Elaine Takane, who could not be here with us this afternoon. And I would like to thank all of them for allowing me to represent them as I share our project with you today. The title of our research project is Self-Reported Health and 10-Year Incident Disability, the Kuakini Honolulu Heart Program. Listed here are the funding sources and disclosures for this research project. The investigators retained full independence and there were no commercial conflicts of interest. Disability and limitations in activities of daily living are important public health concerns because of their association with loss of independence, worsening health outcomes, and higher overall healthcare costs. Self-reported health, or how an individual rates their own health status, has been identified as a predictor in post-hospitalization recovery, chronic disease management, and mortality. Few studies, however, have evaluated self-reported health as an independent predictor for loss of function among healthy older adults. Our objective was to study whether self-reported health can predict incident disability in a cohort of elderly Japanese American men. The Kuakini Honolulu Heart Program is a longitudinal cohort study of cardiovascular disease in Hawaii that started in 1965. Participants were Japanese American men ages 45 to 68 at the time of enrollment in the study, who were living on the island of Oahu. These men underwent serial follow-up examinations over 50 years. The baseline for our analysis was exam 4, which was between the years of 1991 to 1993. During this time, 3,741 men ages 71 to 93 years participated in the study. After excluding those with prevalent disability at baseline, or those missing self-reported health data, there were 2,572 men in our analytic sample who were prospectively followed for 10 years. Our predictor variable was self-reported health, with responses of excellent, good, fair, and poor. In this graph, you can see the baseline distribution of responses that 12% rated themselves as excellent, 59% as good, 27% as fair, and 2% rated their health as poor. Our outcome variable was incident disability in any of the 6 activities of daily living, also known as ADLs, such as walking, transferring, feeding, dressing, bathing, and toileting, or 5 instrumental activities of daily living, also known as IADLs, such as housework, shopping, cooking, managing finances, and using the telephone or other communication devices. There was follow-up at 3 and 10 years. Our baseline covariates or risk factors included age, education level, defined as the number of years in school, marital status, body mass index, physical activity index, smoking history, depressive symptoms, and grip strength. We performed independent statistical analyses for any loss of function in either activities of daily living or instrumental activities of daily living. We used general linear models for ADL and IADL disability rates by self-reported health categories of excellent, good, fair, and poor. We used multivariate logistic regression to calculate the odds ratio of incident disability by each of these categories. We then adjusted for the aforementioned risk factors. And lastly, we performed separate analyses looking at incident disability in both the short term, 3 years, and long term, 10 years. And these are our results. We predicted that there would be a positive correlation between fair or poor self-reported health and the incidence of disability. On this slide, we indeed see that after adjusting for age, the worse one perceived their health to be at baseline, the higher the levels of new disability in ADLs and or IADLs at 3 years of follow-up. These associations are highly statistically significant with a p-value of less than 0.0001 for both categories. And here we see the same trend at the 10-year follow-up. When we look at the numbers in our multivariate logistic regression tables, we find that participants who rated their health as poor had nearly 7.5 times higher risk of developing a new disability in one or more activities of daily living over 3 years, and 4 times higher risk of developing a new disability in one or more instrumental activities of daily living when compared to those who rated themselves as excellent. Over 10 years, they were found to have approximately 7 times and 10.5 times more likely of developing new disability in ADL or IADL respectively. In summary, loss of function with age can have serious health, social, and financial implications. Our study shows that among older Japanese American men in Hawaii, self-reported health can predict the risk of incident disability over short-term and long-term follow-up. Our study had many strengths. This was the first prospective study on the topic in an older Asian population. There was a long duration of follow-up with 10 years of follow-up, and the study included a large sample size and a complete surveillance system with good response rates at each examination. There were also several limitations to our study. We cannot suggest generalizability since our study was focused on Japanese American men who reside in Hawaii. We relied on historical self-reported data. Lastly, as this was an observational study, we were not able to look into why the participant rated their health as poor. From our results, we suggest that self-reported health may be a simple, inexpensive tool for identifying geriatric patients at higher risk of functional decline. Once identified, those patients may benefit from early intervention with physical therapy or occupational therapy, addressing social determinants of health, and looking into their mental health. Future studies are needed to generalize the study populations and then assess the value of early identification and intervention. Thank you for listening. I'm happy to entertain any questions.
Thank you so much, Susan. For our audience, please do type your questions in the chat, but we will be answering all the questions after all 4 presentations have been concluded. But feel free to type your questions now, and I'll make sure we do them in the order that you've presented them. Our next speakers are Dr. Angela Lowe and Dr. Shivani Chowdhury.
Good afternoon. My name is Angela Lowe, and I'll be presenting with Dr. Shivani Chowdhury on our project titled Tea is the Key, Green Tea Consumption and All-Cause Mortality Over 5 Decades in Japanese American Men, the Kuekini Honolulu Heart Program. These are our affiliations: the Department of Geriatric Medicine at UH and Kuekini Medical Center. Funding sources include the NIH and Kuekini Medical Center. There are no conflicts of interest with commercial organizations with regards to this presentation. Green tea has been a popular beverage of choice for centuries. It is rich in catechins, a type of antioxidant. Green tea has been reported to have various health benefits due to its anti-inflammatory properties. These reported benefits include reducing risk of developing certain cancers, reducing cholesterol levels, and enhancing cognitive function. There is conflicting data on the relationship, however, between the consumption of green tea and reduced all-cause mortality. One Japanese study from 2002 that was done by Iwai et al. Showed no significant association between green tea consumption and all-cause mortality in both men and women, while data from a longitudinal Chinese study, as described by Chu et al. In 2012, noted that elderly men between the ages of 65 and 84 who drank 2 to 4 cups a week of green tea have 19% lower mortality risk compared to men who seldom drink tea. Catechins, a type of flavonoid that is found in green tea, have both direct antioxidant and indirect antioxidant effects. Direct antioxidant effects include being reactive oxygen species scavengers and metal ion chelators. Indirect antioxidant effects include being antioxidant enzyme inducers, pro-oxidant enzyme inhibitors, and stress-related signaling pathway suppressors. Given this, we examined the association between green tea consumption and all-cause mortality over a long follow-up period of 49 years in Japanese American men in Hawaii. We hypothesized that higher green tea consumption will be associated with decreased all-cause mortality. The Kuikini Honolulu Heart Program is a population-based prospective cohort study amongst 8,006 Japanese American men living on the Hawaiian island of Oahu that began in 1965. Self-reported green tea consumption was obtained as part of a food frequency questionnaire during exam 3 from 1971 to 1974, when 6,860 men participated. After excluding subjects with missing data on green tea consumption, our analytic sample was N of 5,945. I'm going to hand it over now to Shivani.
Thank you, Angela. All right, so our baseline covariates included in our analysis were age, BMI, physical activity index, pack years of smoking, cholesterol, alcohol use, and prevalent hypertension, diabetes, coronary heart disease, stroke, cancer, and COPD. Subjects were divided into 4 groups based on green tea consumption. These groups were none with 0 ounces of green tea consumption per week, low with 1 to 29 ounces or equivalent to 0.1 to 3.7 cups of green tea per week, intermediate with 30 to 59 ounces, or 3.8 to 7.4 ounces cups per week, or cups per week, or high consumption with 60 or more ounces or greater than 7.5 cups per week. Follow-up data for all-cause mortality was available through December of 2020 for up to 49 years of follow-up, with mortality data essentially complete. For statistical analysis, differences in the baseline risk factors between the tea consumption groups were determined by general linear models. We looked at age-adjusted all-cause mortality rates by green tea consumption groups. We also used Cox proportional hazard model to assess relative risk of all-cause mortality based on green tea consumption groups. So this chart here is of the baseline risk factors by tea group. High green tea drinkers were significantly older, had more physical activity, higher cholesterol, and lower rates of prevalent stroke. Baseline risk factors for BMI, pack years of smoking, alcohol, hypertension, diabetes, coronary heart disease, cancer, and COPD did not show any significance. Age-adjusted 49-year mortality rates significantly decreased from 46.4 to 44.9 to 44.3 to 44.2 per 1,000 person years follow-up in the none, low, intermediate, and high green tea consumption groups, respectively. The p-value for this decreasing trend is highly significant at 0.006. Multivariate Cox proportional hazard models adjusted for age, as well as the other baseline covariates as listed below, showed a decreased risk of all-cause mortality by increasing green tea consumption group, using the no tea group as reference. In the high consumption group, relative risk was 0.91, which means mortality was 9% lower than in those who drank no green tea. P-value of the trend was significant. So in conclusion, high green tea consumption was associated with decreased all-cause mortality in Japanese American men. There was a significant dose-response relationship with lowest risk in the group who drank the most green tea, which is greater than or equal to 60 ounces a week, which is equivalent to at least a standard US cup a day. There was no association between black tea consumption and mortality. Our strengths were, this is a population-based study design with almost 5 decades of follow-up. We had a large sample size and excellent data collection methods. Limitations were the generalizability, since we only studied Japanese American men. Green tea data was taken from a single point in time where habits may change throughout someone's lifespan. And this was an observational study design. In the future, we would need to investigate the association of mortality with the consumption of green tea in other stages of life. In addition, it would be important to also investigate the association between green tea and mortality in women and other ethnicities. And lastly, we would also like to investigate the association of dementia diagnosis with consumption of green tea. Thank you so much.
Thank you, Angela and Shivani, for an excellent presentation. Before I introduce our next speaker, I just wanted to make a little comment and give thanks to some people. The Honolulu Heart Program has been such an amazing study for over 5 decades. And I see that some of the investigators and staff of the Honolulu Heart Program are in the audience today. And I just wanted to give them some acknowledgement and thanks, because without everybody's contribution, none of this research would be possible. I also have to acknowledge Kukini Medical Center. They've been a stalwart supporter of this project, even during times when there was no NIH funding available. Kukini picked up people's time and allowed the project to continue even through those gaps in funding. So I cannot thank them enough for doing that. And I think lastly, just the amazing men of the Honolulu Heart Program and their families. Can you imagine sticking through a research study for this many years? From that original 8,006, there are 9 men still alive. I think the youngest man is now 102 years old. And many of these men were part of the 442nd and 100th Battalion, which is the most decorated unit in the history of the US military. So it has been my honor and privilege to work with this group of men for a very long time. And it's really been an amazing experience. So their legacy continues, allowing our trainees to do research projects like the 2 wonderful projects that you have seen. Our next speaker will be Dr. Timothy Chong. We're going to shift a little bit from research to quality improvement. This is a quality improvement project done by our fellows this year.
Hello, thank you, Dr. Masaki, for the introduction. I'm going to be presenting our project that the fellows performed this year for quality improvement, titled Teleeducation to Improve Communication Between Nurses and Physicians in Nursing Homes. Below, you'll see the fellows' names and our faculty. And here are our acknowledgements below. The background for this project includes nursing homes are required to participate in quality assurance and process improvement or QAPI activities for licensing. Over the past decade, nursing home care has been involving patients of increasing medical complexity. The shift work model and high employee turnover have led to many challenges in communication between physicians and nurses, especially via telephone. SBAR, which stands for Situation, Background, Assessment, Recommendation, is a concise, validated communication tool shown to improve patient safety. And finally, the SARS-CoV-2 pandemic has restricted in-person staff education for a majority of the time, but shown increase in telemedicine use. The objectives of our project were to design and evaluate a QAPI project for geriatric medicine fellows to improve the rate of SBAR use among nursing physician communication, and to employ a video module for staff to watch on existing facility video tablets as an alternative to in-person education. The planning, intervention, and evaluation stages took a total of 5 months. We developed SBAR nursing documentation forms to facilitate use. We also developed a 5-minute educational video, and there was a retrospective pre and post educational survey involving understanding and confidence in SBAR, 10 knowledge questions, level of training, or years of training, whether they were LPN or RN status, and years of experience. We used the weekend on-call logs for the facility, and we monitored them for the frequency of SBAR use. And to analyze, we used paired t-tests to evaluate the pre-post differences in the scores, and the chi-square test to evaluate change in the use of SBAR over time. Our results include the nursing team involved. There was an N of 18. Just for some characteristics, the mean experience was 16 years, which ranged from 0 to 40 years of experience. 11 were on the day shift, 7 on the night shift. The post-video knowledge scores were generally good. It was an average of 7.3 out of 10, with the range being 6 to 9 points. And the self-assessment survey was on a Likert scale 1 to 5. And below it will show the categories of understanding between before and after watching the educational video, and the rating of their confidence pre and post video. It did show a significant change for both categories upon watching the video below. Over the span of about 23 weeks, SBAR was used appropriately for about 54% of the calls. This table compares the pre-training and post-training times and compares the usage of SBAR. And then, as you can see, there was significant change. However, it was decreased from 62% of use pre-training and showed a 46.5% use post-training in the second half of our study. Decrease in SBAR use over time may be related to the recent Omicron surge and critical staff shortages in the recent months before the conclusion of this project. So to discuss the results, for that SBAR use was significantly higher in nurses who completed the virtual training compared to those who did not complete the training. And this table down here shows difference between nursing staff that did not use that training versus those who did get the training at some point. Other findings below. Additional analysis showed that reporting of SBAR use had wide variability among the different fellows. Looking at the data, it ranged from 36 to 72%. The floors largely dedicated to skilled nursing had significantly higher rates of SBAR use compared to those with mostly ICF patients or long-term care. And so the conclusions, the asynchronous SBAR training was easy to access and to use. And the video education module may be promising for further in-house education. SBAR use had a decreasing trend over 5 months, findings which may be attributable to staffing shortages and higher patient to staff ratios in the setting of the SARS-CoV-2 pandemic throughout the study. And finally, the on-call SBAR usage interpretation was subject to one of us 6 geriatric medicine fellows and may benefit in the future from strict standardized guidelines. And that's the end of our study. Mahalo for your attention.
Thank you, Tim. Our last fellow who will be presenting is Dr. Ashok Kannan. He's going to be presenting his research project on the GRACE program. In the meantime, I just wanted to remind everyone, if you have any questions for any of our speakers, any of the projects, please type them in the chat box and we will address all questions at the end of this presentation. All yours, Ashok.
All right, thanks. Pleasure to see everyone. My name's Ash. I am presenting a collaboration between Aloha Care and the Department of Geriatric Medicine. So what we did is we looked at utilization and cost outcomes in community dwelling low-income seniors enrolled in the GRACE program here in Hawaii. So a summary of what I'll be going over in a few short slides will be identifying the characteristics of the population enrolled in GRACE. And GRACE, by the way, is stands for the Geriatric Resources for Assessment and Care of Elders. And that's a program that was newly implemented in Hawaii recently. And I'll be describing the effect of the GRACE program implementation on ED visits, hospitalizations, and cost of care. So originally, GRACE was developed at Indiana University and it included an IDT team. And basically what that IDT team did was they supported the healthcare of high-risk seniors at home, in addition to the care they already received. So they worked with the primary care provider and the patient, and they added this additional GRACE team. The original GRACE team was implemented at large university-based healthcare centers. And in those settings, they did find, the original GRACE trial did find reductions in acute care utilization. They found improved quality of life, and they found cost neutrality. And what I'll be going over is the GRACE program was recently implemented in Hawaii, implemented by, instead of a university-based healthcare system, by Aloha Care, a health insurance provider, in partnership with a community health center. And they utilized an interdisciplinary team that was, like I said, a combination with this community health center and Aloha Care to implement this program and see if they could get similar outcomes. So we went and looked at their data that they had already retrospectively. So we did a retrospective chart review of longitudinal data, and we looked at people who were enrolled in the GRACE program for at least 6 months. And then we compared pre-GRACE outcomes, the same data, ED, hospital, and cost data, pre-GRACE enrollment, that's 3 and 6 months, post-GRACE enrollment. So the study population ended up being so we took an initial N of 47, which fit our initial criteria, and then we excluded 17, and our analysis group ended up being an N of 30. And these were high-risk, low-income patients, 50 years old or plus with chronic diseases, and they're identified as people who were enrolled in GRACE from April 2019 to 2021. And that was a total of 47. And they were excluded, 17 were excluded for being enrolled for less than 6 months, which left an N of 30. And that's how we got our analytic sample of an N of 30. So in terms of data collection, the outcomes that we decided to look at were number of ED visits per patient, number of hospitalizations per patient, and total cost of care. And we analyzed this using pair t-tests. And an overview of the short overview of the demographics, we essentially what I wanted to point out here was our age range, mean of 72.2 with 51 to 94, 60% female, and 83.3% Asian, Native Hawaiian, Pacific Islander. And first thing I'll go over is ER visits. So you see here the blue bars are pre-grace and the orange bars are post-grace. So when you compared pre-grace to post-grace at 3 months and 6 months, at 3 months, we did have a drop of 23.3%. That was non-significant. And a drop of 50% of number of ER visits per patient, 6 months post-grace versus 6 months pre-grace. And that was also not significant. Those were ED visits, and this graph is similar type of presentation except for hospitalization per patient. Again, blue bars were pre-grace, orange bars were post-grace enrollment, meaning they were with Aloha Care and then without not being in grace before, and then they're enrolled in grace afterwards, so part of Aloha Care. So at 3 months, pre versus post, there was a drop of 35% of hospitalization per patient. And at 6 months, pre versus post, there was a drop drop by 33%, both of which were not significant again. And then just look at costs. So, okay, well, the costs go down as well. And they did. So at 3 months pre, blue bar, post, orange bar, drop of 25%, drop of 19% at 6 months. That 25% was 3 months. Again, p-values were not significant. So in conclusion, we did see reductions in ED visits, hospitalizations, and total cost of care after grace enrollment. And those were in people who were enrolled at least for 6 months. And we looked at the 3-month time point and the 6-month time point for the people who were enrolled for at least 6 months. These reductions were not statistically significant, but they were consistent, as in they all did drop. And those cost savings, just to define them, were about $3,015 per patient, and overall about $90,000 over those 6 months. Just something to note: the recruitment, we basically took the people who enrolled in grace over those about 2-year period, and the recruitment was a little bit low and than expected, and that might have been partly due to the pandemic. But the program did run through the pandemic, just slightly lower recruitment than I guess initially hoped. So, well, part of future directions to look at larger sample size and longer follow-up. But like I mentioned before, reductions were consistent. The lack of significance was there, and this may have been due to the small sample size as well. But that's basically it. Plan to continue to follow them and work with them in the future to continue to look at this data, and that's it.
Thank you, Ashok, and thank you all fellows. This is the end of our presentation. So I want you to all join me in giving a great hand to our fellows for doing a wonderful job. They've presented abstracts at the Hawaii ACP conference, at the JABSIM Biomedical Sciences Symposium conference, and 3 of them went to the National American Geriatric Society conference, and 2 were actually selected for the presidential poster session there. So great job, all the fellows. Please, everyone, you can type your questions in the chat box, or we have a small enough audience that you can unmute and ask your question as well. Do we have any questions for our fellows? Or did they do such a good job that there are no questions left? There've got to be some. So if people have questions, please speak up. Okay, we wait for a minute or two just to see if people are going to be typing in their questions.
Hi, Kamal. It's
Hi,
Sherry.
Sherry.
Yeah, great job, everybody. Very interesting. Ash, could you describe again, like how you got all that personnel? Was that already set up, like as a, like all those people, all the professionals to assess the patients? How were you able to organize that? Was that something that was already set up in the health center? Or?
Yeah,
you have
that, on my part, I got very lucky. That was a program that we looked retrospectively into data that the program was already set up by Aloha Care and I don't know, Dr. Wen, you wanted to talk about the program a little bit in that sense, but yeah, no, we didn't have to work on that this year. It was already set up, and that was part of their partnership with the community health centers. But yeah.
This was set up a few years ago, and Aloha Care worked with KKV, and they decided to do this pilot. And so we started we actually had Indiana University guys come in, do a consultation, and help them implement this whole thing. And it was kind of going and doing well, recruiting patients and following through all the race protocols, which are basically age-friendly health systems type of things. And then the pandemic hit, and so we couldn't recruit anymore. And basically just went on, trying to assist and monitor with frequent touches, more remotely than as opposed to in person. But even so, there were some positive outcomes. So that was, limited, I think, by the size of the sample, and also, I would say, also limited by, in-person follow-up. As you know, home visits are super valuable because you just go into the home and you can find out many more things than as if you were, doing it in your clinic or remotely. So,
Sherry, just to let you know, this is a national program, again developed at Indiana University, but it's been really spread across the country. These are highest risk. They're the highest risk, sickest, frailest patients. They have screening criteria for who qualifies, and they get home visits by a dyad of a nurse practitioner and either a social worker or a case manager. And they have these very specific protocols set up for things like cognitive impairment or falls or whatever. So all patients get some screening, and then there's more targeted screening for people who have risk for certain things. And they've shown really good outcomes. They've shown lower healthcare utilization, higher patient and family satisfaction, and lower cost of care. So kind of hitting the triple aim,
while efficiently using a geriatrician role, who isn't the geriatrician for everybody, but, and doesn't do any consults, but actually just the dyad goes out, does a home visit, comes back, and the team, which is an interdisciplinary team, involves pharmacy or mental health or whoever, provides consultation, and then the nurse practitioner goes back to the primary care provider and shares all of these findings and says, can we implement it, and gets the approval, and they go ahead and do that. And so it really helps the PCP.
Yeah. And Dr. Kogan, the full team here in Hawaii was a nurse practitioner, social worker, geriatrician, behavioral health professional, and clinical lead.
Okay. Are there any plans you're so close to getting, it seems like just your numbers are small. Is there any plans to gather more data and to see if you could make the p-value significant?
Absolutely. I'm going to be, not the fellowship anymore, so I have to talk to Dr. Wen and Dr. Blackie about logistics, but absolutely, I'm going to talk to Aloha Care and figure that out. And if not me, I'm sure they'll be doing it. So, but yeah, I know that's the plan. Because that's exactly what you saw exactly what we saw exactly what you're saying. So
yeah.
Yeah, go ahead, Sherry.
Just because it seems like there's a real trend, even if your p-value wasn't significant, it seems like that's a power of your study kind of problem, not design of your study. So it'd be nice to just kind of push it over the finish line.
That's absolutely true. Michaela put a link in the chat box for those who are interested in hearing more about the GRACE program, or actually you can do a PubMed search and there are publications on the GRACE program as well. Any other questions for any of our fellows?
Actually, the link is actually the 2020 Medicaid MCO Best Practices and Innovative Initiatives. And turns out that Aloha Care, this is nationwide, was awarded one of their innovation awards by putting the Hawaii Grace Care program, because it was innovative in the sense that it utilized a payer instead of an academic medical center, or they have actually done a replication project at the VA and VA system, as well as in other practices. And so there's many variations of this, and this one was a payer.
And I think it was the first one in the country to be a payer to run this project, to sponsor it.
I bet Aloha Care knows how much money it saved them.
Yes, and that's where actually we got our numbers from them. We had to, yeah.
Okay.
Yeah. Any other questions about this or any other project?
This would be fun, Kamal, to share this with like MDX Hawaii, you know, those, and like other Medicaid insurers and say, hey, let's do this thing.
Yeah, yeah. Because we all know that there's a small number of patients that uses a huge percentage of healthcare resources. We know that, all of us know that. And most of it is because they keep coming back to the hospital, right? They keep coming back to the ER and keep getting hospitalized over and over and over again. So anything that can help them stay home helps the healthcare system not get overburdened. It helps costs of care. And actually, it also helps patient and family satisfaction, because who wants to keep bouncing back to the hospital, right? So this is really good for everyone. Any other questions, anyone? Michaela has put the link for the CMEs for the evaluation in the chat box as well. So please use that if you want to get CME credit. I guess I'll give it one more minute. And if there are no other questions, I want to thank our fellows for doing a wonderful job all year in your research and QI projects, and a wonderful presentation at Grand Rounds today. We're very proud of you. 4 of the 6 are graduating, 2 are staying on as second-year fellows. And for the first time in a while, all 6 will be in Hawaii next year. So we're extremely happy about that. And we know they will go on to do wonderful things. So congratulations again, and thank you all.
Yeah, good job, guys. Fun working with all of you.
Thank you, Sherry. Okay, bye everyone.